What is metabolic alkalosis? We first have to talk about metabolic abnormalities. Metabolic abnormality is a type of acid-base disturbance where there is excessive accumulation or elimination of fixed acid. Fixed acids are acids which cannot be breathed off as gases by the lungs and must be excreted in the urine. Therefore, when there is excessive elimination of fixed acid or H+ ions from the body, the blood pH will increase above normal level. This is what we call metabolic alkalosis. So, metabolic alkalosis occurs when there is excessive elimination of H+ ions and intake of buffer base. By taking the bicarbonate buffer system as an example, with the intake of bicarbonate ions as a buffer base, more binding of bicarbonate ions with H+ ions occurs, causing more formation of carbonic acid and excessive elimination of H+ ions through excretion from carbon dioxide.
Now, let's talk about buffer solution concept. What is a buffer solution? A buffer is a solution that can resist pH change upon the addition of an acidic or basic components. It is able to neutralize small amounts of added acid or base, thus maintaining the pH of the solution relatively stable. There are two types of buffer solutions: the acidic and alkaline buffer solutions. An acidic buffer solution is the one which has a pH less than 7. Acidic buffer solutions are made from a weak acid and one of its salts, the conjugate base. While an alkaline buffer solution is basic pH more than 7 and is prepared by mixing a weak base in its salt, the conjugate acid. So how does the buffer system works? Let's take the bicarbonate buffer system as an example. Bicarbonate buffer system consists of a weak acid, carbonic acid, and a bicarbonate salt, sodium bicarbonate. In blood, carbon dioxide combines with water in a reaction catalyzed by the enzyme carbonic anhydrase to form carbonic acid, which is a weak acid. The carbonic acid formed is unstable. It will quickly dissociate into hydrogen ions and bicarbonate ions. In solution, carbonic acid is present in equilibrium with the bicarbonate ion via a simple proton transfer reaction. The equilibrium is largely controlled by the Le Chatelier's principle, which states that when stress is applied to a system in equilibrium, the reaction will shift in a direction that will reduce stress. When we have too much hydrogen ions, which mean acidosis, hydrogen ions will bind with bicarbonate ions to form carbonic acid, which dissociate into carbon dioxide and water molecules. As a result, hydrogen ion concentration in the extracellular fluid will be decreased. The carbon dioxide form will then be expelled through exhalation. Similarly, when the concentration of alkali increased, the hydroxide ion from sodium hydroxide, a strong base, will combine with carbonic acid to form additional bicarbonate ions. While sodium ion react with the bicarbonate ion to form sodium bicarbonate, which is a weak base replacing the strong base.
What causes metabolic alkalosis? The persistence of a metabolic alkalosis requires an additional process which acts to impair renal bicarbonate excretion. It starts with the initiating process, due to gain of alkali in the extracellular fluid. It can be from an exogenous source, such as sodium hydrogen carbonate via intravenous infusion, or from an endogenous source such as the metabolism of ketones to produce bicarbonate. It can also be due to the loss of hydrogen ions from extracellular fluid via kidneys or via gut. Maintenance of the alkalosis requires a process which greatly impairs the kidney's ability to excrete bicarbonate and prevent the return of the elevated plasma level to normal. Chloride depletion is the most common factor that causes maintenance of the alkalosis. By increasing bicarbonate reabsorption in the renal tubules, administration of chloride is necessary to correct these disorders. Chloride depletion is often caused by loss of gastric juice, which is most marked with vomiting due to obstruction, because the vomitus is acidic gastric juice. Vomiting and other conditions may involve a mixture of acid gastric loss and alkaline duodenal contents, and the acid-base situation that results is more variable. Chloride depletion may also be caused by diuretic therapy. Diuretic therapy are substances that promotes diuresis, the increased production of urine. Diuretics such as furosemide and thiazides interfere with reabsorption of chloride and sodium in the renal tubules. Urinary losses of chloride exceed those of bicarbonate, which leads to metabolic alkalosis.
The next cause is potassium depletion. Potassium depletion causes Cushing's syndrome. This syndrome is caused by excess corticosteroids that contains mineralocorticoid effects that causes metabolic alkalosis. Alkalosis is most severe with the ectopic ACTH production. A few symptoms of Cushing's syndrome are facial roundness, weight gain, easy bruising, and stretch marks. Next, potassium depletion causes primary hyperaldosteronism. The increased aldosterone levels lead to increased distal tubular sodium ion reabsorption and increased potassium ion and hydrogen ion losses. Increased hydrogen ion loss is matched by increased amounts of renal bicarbonate ions leaving in the renal vein. The net result is metabolic alkalosis with hypochloremia and hypokalemia, often with an expanded ECF volume. Let's move on to the treatment of metabolic alkalosis in animals. First and foremost, it's imperative to identify and treat the underlying cause of metabolic alkalosis. If the metabolic alkalosis is caused by vomiting or excessive loss of stomach acid, addressing the primary condition and preventing further fluid and electrolyte loss is crucial. Intravenous fluids play a pivotal role in restoring hydration and electrolyte balance. Imagine it as a replenishing stream, bringing back equilibrium to the disrupted internal environment. Moving beyond fluid management, nutritional support becomes an integral part of the treatment process. The administration of potassium replacement can be helpful in the treatment of metabolic alkalosis, especially when associated with electrolyte imbalances such as hypokalemia. Examples include potatoes, spinach, bananas, and lean meat. Let's move on to the case study 1 of metabolic alkalosis in dog. A 4-year-old, castrated male boxer is presented with vomiting history. He vomited multiple times daily for 4 to 5 days. To determine the underlying problems and causes of vomiting, laboratory tests was conducted. Look at these lab results. The dog had high bicarbonate ion level of blood, with low chloride, potassium, sodium ions due to losing in vomitus. The high base excess indicated the metabolic alkalosis. Abdominal radiographs revealed a proximal GI obstruction. After stabilization with fluid therapy containing saline and potassium chloride to replace fluid loss and electrolyte imbalance, an exploratory laparotomy was performed. A cloth foreign body was removed from the proximal duodenum. After the treatment of alkalosis, the alkalemia and electrolyte abnormalities resolved over 24 to 48 hours.
Move on to case study 2. An 18-month-old female spayed Australian missed with 5.4 kg weight which housed indoors and no known exposure to toxins. Within 24 hours, the cat experienced muscle tremors and inappetence which progressing to collapse with generalized muscle fasciculations. It also experienced lethargy, a single vomit, dehydration and pain. Lab tests have been done and found out there is a hypochloremic metabolic alkalosis due to a duodenal foreign body found to be a trichobezoar. The diagnosis was confirmed through thoracic and abdominal radiographs which demonstrated gastric dilation. Abdominal ultrasound revealed a dilated stomach filled with fluid containing hyperchoic particulate material and an obstruction in the proximal duodenum. A blood test have been done which revealed severe hypochloremia, hyponatremia, azotemia, mild hyperproteinemia, hemoconcentration, and the most important one that we are focusing in this video is the increased amount of bicarbonate ion which indicates metabolic alkalosis. The treatment includes fluid therapy where the intravenous fluid therapy was initiated using compound sodium lactate at a rate of 10 ml kg/h. Fluid therapy was crucial for addressing dehydration, restoring electrolyte balance, and supporting overall hydration. Secondly, sedation and analgesia. 1.2 mg methadone was administered subcutaneously. Diazepam was also administered to the cat. Thirdly, muscle relaxants. Alfaxolone, a muscle relaxant, was administered in intermittent boluses to address muscle fasciculations. Other than that, metocarbamol was administered per rectum, resulting in a gradual reduction in muscle tremors and fasciculations. Next, correction of electrolyte imbalances. Blood test results revealed severe hypochloremia and hyponatremia. Therefore, specific interventions such as administering metocarbamol and addressing the underlying obstruction contributed to the correction of electrolyte imbalances. Lastly, Surgical intervention. An enterotomy was performed to remove the trichobazole causing the duodenal obstruction.